My name is Lisa Hilme, and I'm Executive Director of Core Group based in Washington, D.C. I want to thank all of you for joining us today, realizing that it is Good Friday, Easter weekend, and Passover. And for those of you that are celebrating, may you have a very peaceful holiday and a blessed holiday. I hope you and your families are safe and staying healthy and sane during these challenging times of the COVID pandemic. Core Group has been hosting these collaboration COVID response calls since February on different themes that were requested and also identified through our rapid needs assessment. The purpose of these is to have collaboration, networking, and sharing of resources to avoid duplication and also start new partnerships. And I'd like to start by thanking Avani Dugaraju from Core Group, who is behind the scenes helping with our WebEx as our communications and knowledge management coordinator, and Julie Dargis, who is Core Group's new senior advisor for the COVID response. Past topics have included community engagement, digital health, risk communication, and civil society needs. And we'll be having future topics each week based on the needs and the requests as they emerge, such as children and youth, or mental health, or we may redo digital technologies as those develop. In my opinion, today's topic, however, is one of the most important. Today we are examining gender, emerging issues, and recommendations. And we hosted this topic due to multiple requests from partners who want to inform their programs and implementation at the country level. We do not define gender as binary, and today we will discuss issues facing women, men, and the LGBTQI community. It's imperative right now that we start to tackle these gender issues immediately in this COVID response and together, or we'll be facing very long-term health, social, and economic consequences for women, their families, and communities. Government and donors must also act now in their policies. And usually on these calls, we have a great combination of governments, donors, as well as civil society policymakers. So I hope today's call will be also very useful for them. In every response, we should be looking at gender transformative indicators to address the issues you're going to hear about today. So I'm very thankful to all our presenters who are gender experts and will be sharing some of their the emerging evidence that's coming out, as well as offering some recommendations. Some details about this call. All of these slides will be available on the Core Group website, and also the past calls are recorded and you can log in and listen to them, as well as look at the COVID resource page, in which we are gathering many of the resources from WHO, UNICEF, and our partners. Please introduce yourself in the chat box that many of you are doing already, so thank you. Please ask your questions in the chat box, and we'll also open the microphone later for questions. And if you'd like to introduce a future topic, or if you'd like to present, please contact Core Group and we'll I also ask you to mute yourself if you are not speaking, because it will give background noise. There'll also be a time where they're going to be asking you some questions, and I'm going to give a shout out to David for that recommendation. Thank you, David. During this presentation. So if you can please put your responses in the chat box. I'm now going to turn it over to Dr. Julie Dargis, who is Core Group's new senior advisor for the COVID response. Thank you again for joining us, and I'm looking forward to an excellent presentation. Over to you, Julie.
Thank you so much, Lisa. It's great to be here, and thank you for that great introduction. We have some really amazing, creative, and committed professionals with us today, and we're so happy. And so I'm just going to very quickly go over the agenda with you. Thank you, Lisa, for the opening. I'd like to introduce to you Dr. Carolina Mejia. who will be our moderator today. And as Lisa said earlier, she brought this issue to us and she wanted to work with us on this. So she's been instrumental in pulling this call together. And as a member of Core Group, we certainly appreciate that. We're going to have 5 presentations today. We'll have 2 presentations and then we'll pause for a round of discussion. In the background, we'll be pulling your questions and sharing them with Caroline, so she'll be able to moderate a discussion. After the second round of questions, we'll have a second round of discussion. And then I'll just take a few minutes to really bring you a little bit deeper dive into the wonderful resources that we have on the website. And then Lisa will close the call for us today. So our presenters today include Dr. Samira Tuwajiri. She's of the World Bank, and she's going to talk to us today about the World Bank perspective on gender and COVID. Following her presentation, Anushka Kalyanpur from CARE will present the findings from the rapid gender assessment, which is really well done, and I believe they did that with IRC, both core members. We'll have a discussion after that. And then Constance Newman from IntraHealth will provide a discussion on frontline workers, which is one of the issues that we've been grappling with this week, pulling this call together. From Promundo, we have Giovanna Laura, who will bring in the men's perspective, and then we will close with Ann Keeling, who will be representing the Women in Global Health organization, which has put together this wonderful 5 asks, which I believe has been gaining just such great traction. And I'm going to leave the slide now for Carolina to take over. And again, welcome everyone to the call. As Lisa said, we will have some questions. We'd like to encourage you to answer the questions and engage with us because it helps us to understand the needs and what we can do in future calls. So without further ado, Carolina.
Hello, good morning, everyone. Sorry about that. Thanks for joining today's presentation. We have convened this call because we're all deeply concerned about the adverse and disproportionate effects that COVID-19 has on the pandemic. We will likely, sorry, I'm getting some interference. Julie, can you hear me? Can everybody hear me?
Yes.
Okay, good. Yeah, I was getting some interference. So as I was saying, we've convened this call because we're all deeply concerned about the adverse and disproportionate effects that COVID pandemic will likely have on women and girls, men and boys, and the LGBTQI communities and other marginalized populations around the world, particularly in development and humanitarian settings. Through this core group call, we want to explore gender implications of the pandemic and how national governments and international donors can respond during and after this crisis. The COVID-19 outbreak is another opportunity to build on some of the lessons from Ebola, SARS, and other deadly outbreaks. Today, you will hear from 5 presenters discussing gender considerations during COVID. Most of this gender challenges, I must say, have already existed before COVID, but now they are being greatly exacerbated during this crisis. We know that pandemics and the resulting economic shocks affect women and men differently in other populations as well. Physical, cultural, and social differences between men and women can influence how vulnerable they are. Women are vulnerable to COVID due to their economic insecurity, overrepresentation in certain sectors in the economy, their caring responsibilities, and healthcare sectors. Data show that women comprise 70% of the healthcare workforce. Frontline workers are working long hours under great and intense pressure at this time sometimes without the necessary personal equipment, which puts them at risk of contracting COVID infection. The burden of care falls greatly on women, not just of caring for their children, but also for their extended family. We know that during this times of quarantine, women are facing many challenges, including violence at the home. On the other hand, men are being impacted in different ways during this pandemic. Men could have more underlying health risk factors than women. They could also be engaging in more risk behaviors and perhaps greater risk of smoking and drinking alcohol. So we will hear from our presenter from Promundo about this. An article in The Lancet called for more research to understand the gender impacts of COVID in order to create what they say it's effective, equitable policies and interventions. However, we already have some indications based on available data that shows COVID is not gender neutral. In our discussion today, we cannot ignore the need to close the gender gap. Pandemics require driven decisions. While coronavirus is a unique virus that has spanned the globe, individual nations, communities all face it within their own context. The lack of sex, disaggregated data, and gender analysis is not unique to COVID response, but reflects a wider trend in global health. As the COVID-19 crisis develops, it will be important to continue to collect sex-disaggregated data and gender indicators for analysis as the crisis unfolds, particularly in local level responses. I'm going to stop here now to allow time for our presenters to expand on these topics. Next, I'm going to give the floor to our presenter, Dr. Samira from the World Bank. Over to you.
Thank you, and good morning, everyone. It's a pleasure to be among this group, and my thanks go to my colleagues at the core group. It's true that any time anything threatens development, the gender dimensions sort of jump out of the window, unfortunately. But it's also gratifying to see that at the same time, groups like this one I'm talking with this morning jumps to action. So it's something that we need to deal with, whether we like it or not. So what I'm going to do is I am going to very quickly go through some of the things that we've been doing at the bank, and I meant for this presentation to be really quite granular because on one hand, I didn't want to lecture you. Actually, I learned from most of you, but at the same time, I just wanted to sort of lay the context against which we are doing. So as was indicated before, and in many of the introductions, that gender norms and development are interlinked. There's nothing we can do about trying to change them because they are embedded in people's culture, in people's beliefs, in people's religions, and in people's way of life and the way they choose to go about it. So they are a group of beliefs that define how our values are actually embedded into our own expressions of identity and what have you. And then there are the expectations from probably before the time, even the time of birth, on how boys and girls would behave. And that set of expectations usually puts that burden squarely on the shoulders of women and girls. And this was discussed in the beginning. I mean, I often take myself as an example. I mean, I am a sort of a top-tier professional in an international organization. I have a job security. I have health insurance. However, on the other side, I am a single mother with children to cater for, and not just financially, but also emotionally. And if you have asked me what is the single most thing that I actually fear, is that I fall sick and I don't know what's going to happen to my kids. So it doesn't really matter how much of a social security background and protection we have, there is always something that's going to give in. And I think we've all been hearing from our colleagues and our friends and our families on how suddenly all of our social services were cut off, working from home, and and trying to actually also follow up on the education of our children. And again, this is a first world problem more than anything else. And I'm sorry I'm putting this out. It's just that an exaggeration of the magnitude of the problem. So because of gender being really central into everything we do, it is an important social determinant of health. And I'm talking from the public health perspective. I'm a public health physician, and most of what we do within this domain, the COVID-19, is actually has to do with it being a public health pandemic and a public health problem. Just very quickly to run through some of the other social determinants of health: income and poverty, obviously, and this is when I say gender, men and women, employment conditions, social inclusion and exclusion, and also education. We have all been involved into levels of education and different health indicators, the least of which are not maternal mortality and infant mortality and what have you. So just coming back to the bank, I just finished submitting a paper to the board, which looks at multi-sectoral approaches to the way the World Bank as an international organization actually deal with the COVID-19. And this piece of work is being finished with the addition of the fiscal difficulties and the macroeconomics, which is outside my expertise. So if you look at the circle on the left-hand side of this slide, you will see that public health is in the middle, and everything around it goes around it. And we've picked some of the, this list is not exhaustive. We picked some of those areas where we can intervene, and there are services that are impacted, and at the same time, those services that can be made better. So we have transport, agriculture and food, water and sanitation, public services, social protection and jobs, and of course, education. Education has a very interesting dynamic into all what we are doing, simply because of the ability of students to access some of the digital platforms during the lockdown. And then on the cross-cutting issues, we have the human capital, gender, social cohesion, and citizen engagement, climate change, fragility, conflict and violence, and displaced populations and populations on the move, not necessarily forcibly displaced. And we've seen a lot of challenges that are coming from foreign workers being in one country and wanting to be repatriated to their own, or losing their jobs and being stuck somewhere where they cannot do anything. And finally, procurement, because we know that the supply chain is a huge issue within what we are trying to do, even in this country and some of the industrialized countries. So I'm just going to focus on the slide that has to do with gender. As I said, this is part of a bigger presentation and a bigger paper. So we need to make sure that gender comes up in the pandemic response. And on the right-hand side of the slide, you will see that there are some suggestive bullet points, among which are we have to make sure that the community information campaign reach women. We need to consider language, culture, mobility, or even the ability to read and write, and the access to all of those media outlets. We need also to ensure that there is support, training, protective gear to front healthline workers, and we know that the biggest population of frontline health workers when it comes to nursing and ancillary services are women. And these women are mothers and wives and partners and caregivers. So we really need to make sure that these women, A, know how to protect themselves, and B, they have actually access to the protective gear that they need, and also access to some of the psychosocial support, because we know that this is going to have a long-term impact on all of us. But I think it's much more on the caregivers. We also need to be very mindful of the informal caregiver that are fall into the category of the informality, which is really across the board in terms of financial relief, things that actually have to do with mobility and transport. And also, we've heard a lot about governments and states repurposing some of the reproductive health and sexual health services to deal with the COVID-19 response. While the first priority should actually go to dealing with the pandemic because it's a matter of life and death, but we really need to also make sure that both the reproductive health commodity security supply chain remains intact and the services also remain intact. We also need to be mindful of the spikes in the gender-based violence due to all of the dimensions the pandemic puts on units, different units, whether it's a family unit or individual unit or societal units. And also, we need to make sure that, very much like any other emergency, that the care packages would include feminine hygiene products because those are sometimes not available. Now, what are some of the key issues that we're trying to combat? It was mentioned before, and I'm just going to sort of sail through this slide. There are basic biological differences in the reaction to the virus, and there are differences in incidence and treatment. There is a very recognized impact on the elderly, especially women, and we know that women usually live a bit longer than men, but this length of time that they live is not always a gain on their human capital because there are all the comorbidities and there is exposure to different pandemics. We need to be mindful of the support to healthcare workers and informal caregivers, continuity of the critical care for maternity and healthcare, and also mitigating risk for gender-based violence and sexual harassment. Now, within the bank, our policy measures for healthcare have been classified under 3 broad categories. We need to be very diligent in the disease surveillance and pandemic preparedness, but this is under the best case scenario or ideal case scenario. We need to have a public health emergency response that includes immediate measures to actually combating the virus and also supporting measures for the strengthening of the health system and promoting the continuity of the emergency response. And we all know that this pandemic had actually exposed a lot of gaps into our health systems, from the developing countries to the more industrialized countries, and the range of response and the range of impact is actually on its own is a textbook. I mean, I hope we will all have the opportunity to go back in time and study what had been the response and what had been the cost of delayed response or the cost of inaction. And then finally, measurement, and Lisa and other colleagues have actually stressed on this and the importance of actually not just sex disaggregated data when it comes to basic indicators, but also gender indicators, and specifically gender transformative indicators that can be used to analyze gender responses and gender differences and what have you. I think this was my last slide. It was. I will stop here, and I thank you again very much for your attention. Thank you.
Thank you, Samira. Hello, everyone. My name is Anushka Kalyanpur, and I will be presenting on behalf of CARE along with my colleague, Courtney Phelps. And we will be presenting on CARE's rapid gender analysis for COVID-19, first on the global level, and then specifically related to the Middle East and North Africa region. So what is rapid gender analysis? As you all know, gender and emergencies is really core to CARE's programming. And so at the beginning of every emergency, we undertake something called a rapid gender analysis, which really, the purpose of this is to provide information about the different needs, capacities, and coping strategies of women, girls, boys, and men in a crisis situation. It does this in part by examining the roles and relationships between women, girls, boys, and men. And essentially, the rapid gender analysis is built up progressively. It acts, it provides some initial thoughts on, and is usually an incomplete analysis of gender relations in an emergency, recognizing that gender and social norms may also change before and after a crisis. So this approach, or the rapid gender analysis approach, is now available in a toolkit form, and this is available online, along with a complementary set of videos. And essentially, the RGAs, the rapid gender analyses, have been used now since 2013 in over 50 countries in the world. The real purpose and real principles of doing a rapid gender analysis are ensuring that we're doing something quickly and progressively, and to ensure that that there are really practical recommendations for practitioners, for donors, for policymakers at the very beginning of a crisis. As Samira said, often in an emergency, in an epidemic, we get into our different sectors that we're working on and don't think about the gender dynamics. So the purpose of this is to really, from the very beginning, from the early days, get this on people's agendas, and then, on an iterative, progressive way, really build on it. So, we like to clarify that RGAs are imperfect. They require updating and over time. So that is just a little background on the rapid gender analysis. I also wanted to mention quickly that that the rapid gender analysis is part of a gender analysis series for COVID-19. So in the very early days of COVID-19, we also released a care policy paper, which is also available online, followed by this global rapid gender analysis that I'll be talking about a little bit today, followed by local and regional level RGAs, and Courtney will be talking specifically about the MENA region rapid gender analysis. But, in summary, and building on what Samira and others have said, we know that disease outbreaks affect women, girls, men, and boys, and persons of all genders differently, as well as at-risk and marginalized groups. The impact of COVID-19 with the compounding complexities of development or humanitarian contexts are likely to have disproportionate effects on women and girls, as well as within these marginalized and more vulnerable groups, while also exacerbating pre-existing gender and intersectional inequalities. So essentially, as we mentioned today, the rapid gender analysis really works to build and create linkages to the various different discussions and dialogue that are happening on gender analysis as it relates to the crisis at hand, in this case, COVID-19. So I will just summarize quickly. So this whole paper is online, of course, but I wanted to highlight some of the key findings from our global rapid gender analysis. So who is affected? We know that, to a greater extent, we know that that it's men, it's people with underlying morbidities, existing morbidities that are being adversely affected. In particular, the direct risks are affecting older people over 60 and above, and those with underlying medical conditions. Men seem to be slightly more at risk with regards to morbidity than women. However, this definitely needs to be further unpacked. We know that women and girls and other at-risk vulnerable groups often experience secondary implications stemming from health crises and other crises due to gender roles, responsibilities, and social norms, including the division of labor both inside and outside the households. And this, takes its form in paid and unpaid work, access to and control over resources in the household and the community. So first, let's talk a little bit about caregiving burden. We know that globally, women perform 76.2% of unpaid care work, almost 3 times that of men. This includes caring for elderly or sick relatives who in this crisis are more susceptible to increase complications from the virus, as we've discussed. Secondly, caring for children with schools closing. This is likely to add increased burden for women who will be juggling paid and unpaid work. And also, as health systems, particularly weak ones, become overwhelmed and cannot attend to all cases, women will likely bear the increased burden of caring for patients that the health system cannot cover. This increases women's risk of exposure, as well as limiting the time they have to engage in other work and economic opportunities. This would have compounding impacts on single-parent families, as well as those from low-income families, the self-employed, those without employment health rights or benefits, and those who cannot afford or access childcare or to take time off. Another thing to really highlight is women in leadership or decision-making. We know that globally, 70% of workers in health and the social sector are women. But in a study by the World Health Organization, over 70% of CEOs are male in global organizations active in health, and only 5% of women from low and middle income countries. So these statistics really, demonstrate the extreme discrepancies in women in leadership and decision-making positions. And this is definitely something that we need to keep in mind as we move forward, so that even the decision-making groups really reflect more gender balance. For example, we know in the U.S. that 100% of the current coronavirus task force for the U.S. government were male at the time that this RGA was developed. So really thinking about the critical gap and need for having gender specialists at the decision-making table, irrespective of what kind of crisis we're dealing with. Of course, women's frontline interaction with communities and women's socially prescribed care roles, which take place in a prime position for them to identify outbreaks and trends at the local level, also put them in a position that makes them more disproportionately impacted. But they're still excluded from community level decision-making processes and government structures that the response would be shaped by. So I think I'll pause there and move on to the sectoral findings. I think something that has really been top of mind for all of us in this sector has been gender-based violence. We know from China, for example, from COVID-19 impact, that women's rights activists in China reported that domestic violence cases have risen dramatically as people across much of the country were quarantined during the coronavirus outbreak. Lockdown and violence meant that individuals, particularly women, were essentially trapped with their abuser, which is obviously very concerning, particularly when access to GBV services and availability of GBV services is even more limited. I heard from a colleague yesterday, in fact, that in Lebanon, one of the national hotlines reported 100% increase in calls related to domestic violence during this period. Sexual exploitation and abuse is another major concern in light of the economic downturn and food insecurity that COVID-19 is having. Finally, I really want to emphasize the decreasing access to healthcare, and in particular, sexual reproductive health. We know, for example, from other epidemics like Ebola in West Africa, that there was 50% reduction in access to healthcare, which resulted in increased malaria, HIV, TB mortality rates, which with an increased burden on obviously the most vulnerable groups. Again, the scale of COVID-19 pandemic means that resources are already being diverted from existing health services to support the crisis, and may lead to a shortage in health professionals, financial resources, and supplies as well, including for SRHR, for sexual reproductive health and rights. We know that in many of the contexts where we're working, there is a pre-existing poor access, restrictive laws, and weak health systems related to unequal gender and social norms, and this exacerbates and limits access to life-saving SRH services, including contraception and emergency obstetric newborn care. I'm going to pause there and hand over to Courtney to speak briefly about the MENA region.
Thanks, Anushka. So just in line with what has already been mentioned in terms of the broad global trends, I wanted to pull out, we just recently finished a rapid gender analysis for the MENA region based on existing data. So I wanted to highlight a few things that we're seeing within the region that might be of use for this conversation. As you can see in the map, it's quite a diverse region. So we're talking about a span of 3 different continents. I know everyone has kind of a different configuration or categorization of what Middle East and North Africa looks like, but for the purposes of the next few minutes, we're talking about the countries in which CARE is operating in both humanitarian and development contexts. So as you can see in the map, it's incredibly diverse. So we're talking about some scenarios in which we are working in very kind of, or to a certain degree, stable context, and others in which we have protracted conflict and crises and dramatic emergency contexts. So the degree to which the COVID-19 pandemic is affecting countries is quite different depending on the country that you're talking about. As of earlier this morning, every single country in our region now has documented cases. Now that Yemen has officially confirmed cases of COVID-19, we have every single country in the region impacted by the pandemic. As you can see in the different countries that we're talking about, one of the things that's unique about MENA is that there's a substantial proportion of refugee, displaced, and other migrant populations. So it's a very conflict-affected region, which really changes the dynamic of how the virus spreads, as well as how we're able to address the pandemic. So we have a lot of difficulty in tracking the virus spread because there's a lot of informal migration through Turkey, Greece, Syria, Iraq. There's a lot of kind of porous borders that make it very difficult for us to track the virus, but there's also particular vulnerability given the immense amount of humanitarian needs that were already existing before the pandemic came to the region. So we have, we're facing in the next coming weeks and months a very strong potential for this to become crises upon crises upon crises in the region, and so that it's going to be particularly difficult for us to address. We'll talk about it in a minute as well, but it's also the most water scarce region of the world, and so the ability for us to address some of the global recommendations around preventing the disease are very difficult for the region. We already had millions of people in the region who needed emergency wash assistance, and that is only going to become more acute. We also have some border closures that make it very difficult for us to enable materials that are critical for WASH assistance to come into countries that need it. So for an example, in northwest Syria, in a displacement camp assessment recently, we had about 91% of populations that had zero access to soap and 45% of locations that had no latrines whatsoever. So the WASH assistance and potential for this to spread exponentially is going to be quite significant in the region coming soon. So that's just kind of a general understanding of what we're looking at. Anushka also mentioned a bit about the levels of unpaid work for women across the world and how that impacts women, particularly in MENA. We actually have an even higher rate. So the actual rate is 5 times the amount of unpaid work that women do versus men in the region. So we do have a strong gender component in terms of the impact that we're going to see on the labor market within the MENA region. So just moving to the next piece, I just wanted to pull out a couple of key themes that we're looking at, particularly in MENA. Even prior to the pandemic, the level of mobility for women and girls was quite reduced, given some cultural aspects as well as other safety and risk concerns that are unique to conflict and displacement settings. So there's a lot of already cultural limitations around women's access to services, and that is being only more exacerbated by the fact that the region in particular has taken quite stringent measures to reduce movement. So a lot of the countries in the region have taken very strict measures to physical basically displacement, so that people are staying in their homes, and that means that women and girls cannot access the level of services that they need. This has also has impact on the access to information. So while the MENA region has quite high levels of technological infrastructure, and they have social media, and they have access to your typical means of communication, this is really different in rural communities, and it is also different by gender. So women and men share information quite differently, which has a huge impact on how we're sharing preventative information as well as how we're sharing information on how to access services. So it's quite differential. There's also a trend in the MENA region around stifling the amount of public information that gets shared. So there's quite a lot of restrictions around journalistic reporting as well as other types of information that gets shared. So it's something to be considered in the region as we look at not only the right guidance around behaviors and practices, but also who is getting that information. There's, in terms of as well as mobility, there's a huge disparity in terms of disability populations as well. So you have a really broad range of prevalence around disability. You have up to 27% of the population in Syria, for example, that has a disability, particularly conflict related. And so that means that mobility is even further impacted by the crisis for them, and they are isolated in their homes. So that's something that we're definitely looking at within the MENA region. We're also, as I mentioned before, the population of IDPs or displaced populations, refugees and migrants is substantial. This makes it really, really hard for us to control the pandemic with overcrowded conditions. The border crossings, again, are quite unsafe, and there's a lot of family separation. And so we're looking also particularly at the impact on children who might be separated from their families, who may not have access to services. And another thing that's unique to the region is looking at documentation concerns within these migration patterns. So there's a lot of limitations around access to services if people are moving across informal border crossings and don't have their civil documentation to enable them to access services. So that's something that's very critical in the region, even prior to the pandemic. There's also quite a lot of diversity, as mentioned, within the region, and so this impacts as well the way that we deliver services, and we need to be very cognizant of that. So a lot of people think of MENA and they think that it is entirely Arabic speaking or Arabic descent. This is clearly not the case, as you've seen in the map of countries that we consider within MENA. You have a lot of different linguistic and ethnic diversity within the region, and that makes it critical for us to look at how we're designing our services, both in terms of just even translating materials in languages that are not maybe predominant, such as Turkish or Kurdish or other languages in the region. But also we're looking at just the complications in providing consistent and contextualized information that takes into consideration religious background. One of the things that Anushka mentioned in terms of health service provision is quite unique to the region. Women and girls can't access that if it's not provided in a contextualized manner. I'll move. I know we're running out of time. Some of the key findings that we're looking at for MENA, just to pull out, in addition to what Anushka mentioned, wash service availability is a huge concern in the region. I mentioned it's the most water scarce region, but it's also, we already had millions of people needing emergency assistance prior to the COVID crisis, so we really need to look at how we can provide wash service availability, especially given some of the importation and border concerns. Psychosocial support is also a really critical concern. This is, again, this touches every corner of the world given pandemics and crises like this, but given that there's so much conflict and displacement in the region, the levels of MHPSS needs were already extremely high and extremely undermet prior to the pandemic. So this is only going to increase, and as Anushka and others mentioned, this contributes to exacerbation of gender-based violence in the home given lockdowns and other restrictive movement measures. So psychosocial support is a really, really critical concern that we have for the region.
Sorry.
We also,
the timing, we really need to move on because we have the other presenters and we want to have discussions. So if you can maybe wrap it up in the next minute. Thanks.
Sure, no problem. Yep, and then we're looking also just at women's leadership. So there were some gains made in the last few decades in MENA, and we just want to make sure that those are not at risk. Just moving on to recommendations, some of these have already been touched on, so I'll just move really quickly. We're looking at, again, consistently sex, age, and disability disaggregated data. So sexual and reproductive health, including GBV services, needs to be prioritized. We want to really look at how we can engage women and girls at the community and at global levels in leadership and participation. So we need to think about how that can be contextualized for MENA. wash services we've talked about. We want to actually look quite closely at economic measures in the region. There's a lot of work that's been done on women's economic empowerment and engaging women in livelihoods in the region, and that is very much at risk at this stage, particularly given struggles with home-based work and caregiving responsibilities for women. So that's something that we really want to make sure is prioritized. MHPSS I've mentioned as well, and then we also want to look at the risk of sexual exploitation and abuse, given that there are major service demands and very, very limited resources. So those are things that we're particularly looking at in conflict and displacement settings. Apologies again for going a bit beyond the time frame. We'll be able to provide a report which has more details for anyone who's interested.
Great. Over to Carolina with questions. Carolina, you might be on mute. Carolina, you on? Thank you. Carolina? Okay. While Carolina gets her sound up, can you all hear me? Okay, well, I can hear you. Okay, great, thanks. So there's been several questions. I've been sending them to Carolina, but until she gets her sound back up. One of the questions here we have, given that the health system already has a role in gender-based violence response, and that's not often going well, and we're seeing an increase, how can we call on the training of health workers that's practical? And how do we address some of these intersecting pandemics and issues during the pandemic? So that's one. I'm going to do one more question I've been sending them all to Carolina, so let me quickly go back. For Samira, can you talk a little bit more about what World Bank is doing specifically in terms of the financial access, incorporating gender into your loan policies, or how you specifically are addressing gender issues in some of the work that you're doing? So we'll do those two questions for now. And then I think once Carolina, I don't know if she has, I don't see a mic next to her yet. So why don't we go ahead with those? Thank you very much. So Anushka or Courtney, if you want to take any of those, or in terms of the first one about what do we do about gender-based violence now? And remember to unmute yourself.
Sure, I can start, and Courtney, please jump in. But essentially, I would say that, right now, what we're seeing is we're needing to adapt our existing approaches, of course. So several of our country offices, for example, are, working to essentially, create hotlines or support systems where, we can have helplines, SMS kind of support, any kind of remote support that can be helpful for people that are in need. I saw the point on integrating sort of training in preparedness, which is obviously crucial. I think in some places, depending on where we are with the sequencing of the crisis, that's feasible, and in others it's not. So I think in general, just working with the local system, updating the referral mechanism to ensure that we know exactly what is functional and non-functional, ensuring that frontline health staff are even supported on disclosures for survivor-centered approaches. There's also a really great document that was just released in the last day or two, an interagency document on GBV risk mitigation across sectors, which I can pop in the chat box as well. Courtney, I don't know if you want to say anything.
Yeah, I think the only thing I would add to that is just that we're also really looking at, particularly in MENA, but also globally relevant, is how we can work with men and boys in terms of really dealing with some of the social norms and attitudes that are exacerbating gender-based violence in the home. So we're really looking at how we can adapt some of the modalities that we've already been developing to kind of work with men and boys in terms of attitudes and behaviors and perceptions. So that is something that we really want to focus on. We in the region have really struggled a little bit with trying to kind of recalibrate some of those really entrenched gender norms, and I think this is an opportunity also for us to make sure that we are figuring out how to reinforce strong joint decision making and strong MHPSS support for men and boys as well. So I know we talk a lot about women and girls, which is of course they're bearing the brunt of GBV, but I think we need to, we're also looking at how we can do that within the context, because a lot of GBV survivors in the pandemic are stuck within the same home as their abuser. So we really need to make sure that we're also figuring out not only how they can access resources and support, but how men and boys themselves are getting, or how we can mitigate the risk of GBV in the home.
Right. And
Thank you, Courtney.
I'm going to do one more for you also from Mbenge. Is rapid gender analysis actually reproducing gender binaries because everything is about men, women, girls, boys? And can you address that, please?
So, we should have clarified. So essentially, the way the questions are structured, we don't specifically ask about only about men, women, boys, and girls. The questions are broader, and then it's probing about, how does this affect certain groups differently?
Lisa, the connection is really poor on my end. I'm not sure I heard the question.
Okay, I think Courtney heard it. She's starting to answer.
Sorry, can you guys still hear me?
Sorry, yes, we can hear you. Understood.
Yes, so essentially what I was saying is it's more about looking at the gender and social norms and how it affects different subgroups. So it's not limited to men, women, boys, and girls. Often we probe for any social and gender and sexual and gender minority groups and how they are affected as well. So even though in we talk about men, women, boys, and girls, what really comes out of the discussions are much broader and looking at gender, social norms as well as power and how that affects different vulnerable groups, again, across, including within subgroups and intersectionality.
Thank you so much for that clarification. I think that was important. And now over to Samara. Samara, the question about how is World Bank in your work really ensuring and addressing GBV and some of the gender issues and maybe the financial policies and beyond?
Sure. So the bank was very quick to respond in allocating some $12 billion to help, especially IDA countries, the low-income countries. And within that, we have submitted to the board for approval 25 projects last Friday, which is a record within the bank ecosystem, to actually put a project together in about 2 weeks. And in all the 25 and all the ongoing projects, we are working on the second batch. We've asked task team leaders to consider 3 questions. The first one is that, is there a gender gap they are trying to address? And there is often one. The second one is what measures they are taking within their response, within their project development objectives and indicators, what are they doing to reduce that gap? And finally, what indicators are they going to be measuring to go back and measure that gap that they have identified in one? And all the 25 projects actually have some element or the other of the gender gaps. We have focused on education, social protection, and health, of course. As I said at the beginning, health is the anchor of all of this. So within the education, we've looked at different aspects of the access to the digital platform, to in areas where there is no connectivity to radios and to other media outlets. We looked at meals for children, and of course, we looked at supporting the household, which is the unit that's all of this social assistance is anchored. The same goes for conditional cash transfers. And I just wanted to mention that during the Ebola crisis, the bank started something called the PEF, which is the Pandemic Emergency Funding Facility. And there has been a lot that's said about the PEF in the past few weeks because there were a couple of conditions when the PEF becomes activated, depending on the epidemiology and the number of identified cases, and also the window of time between the identification and the declaration and the access to funds. So this facility became active yesterday, so we are going to have even more resources dedicated to all of this, and among which, of course, is the gender considerations. Thank you. Over.
Wonderful. Thank you.
Carolina, are you back?
Can you hear me?
Yes, great.
Okay, great. Sorry, I don't know what happened there. Some technical difficulties that we're all trying to adjust now, being in our home offices. Well, thank you for the responses. We want to move on to our next presenter. So I am going to pass the floor to Constance Newman, who will be presenting on about frontline health workers. Candy, over to you.
Thank you, Carolina. Hello, everybody. My name is Constance Newman. Some of you know me as Candy Newman. Can you all hear me? Just one person say yes?
Yes.
Yes.
Great. Thank you very much. Okay, so I'm going to present on the gender implications of COVID-19 for frontline health workforces, and I'm very impressed that so many points that I was going to make have already been made, and that I see from not only the presentations but from the chat box that people are very much understanding a lot of these issues already, gender and COVID. So what I'm going to do is just take some of those points and tweak them and maybe augment them with respect to the health workforce, the frontline health workforce. So let me just start off by saying that, the State of the World's Nursing report just came out this week, which is very, very interesting. Not only do we know that about 70% of the health workforce is female, but that nurses and midwives make up 59% of the health workforce, about 28 million people. 90% of nurses are women. The frontline health care service delivery workforce, the formal one, is predominantly a female, executing so-called female-identified jobs. As a recent WHO publication observed, healthcare is delivered by women but led by men. And I've only been talking about the formal healthcare. Also, we know that there's an informal healthcare workforce, on or underpaid, and that is predominantly women also. What I would like to do is ask for your patience while I present 4 introductory slides to give some context. Yes, thank you very much. So you might be wondering why in the middle of this COVID emergency, I'm showing these Sustainable Development Goals. And that's because COVID is going to have long-term impacts on the pipeline of health workforces. And that's why Sustainable Development Goal 4 is there. And it will have these, hello? Yeah? Can you hear me?
Yes, we can hear you. Go ahead.
Okay. So COVID-19 is going to have a long-term impacts on the pipeline of health workforces as a result of the disruptions to education. And these are going to have to be addressed as we recover from the first wave of COVID-19 and prepare for subsequent waves in a framework of sustainable development. Sustainable Development Goal 8 is there to remind us that we need to be concerned with the provisions for decent work that have been put in place or that need to be put in place in health employment systems to preserve the health and safety of the frontline health workforce. And Sustainable Development Goal 5, gender equality, reminds us that as with sustainable development, we really cannot lose sight of gender equality in our attempts to respond to gender issues in the healthcare workforce. Next. Next, please. Yeah, I just wanted to say that even though we are in the midst of a health crisis, in many countries, health delivery crisis, that the goal of decent, safe work for healthcare workers at the front line is not a luxury if we want to preserve an effective frontline workforce. Though decent work, these rights that you see here, employment that respects the fundamental rights of the human person, as well as the rights of workers in terms of conditions and work safety and remuneration, including respect for the physical and mental integrity of the worker in the exercise of their employment. Though these may seem like luxuries, they can't be overlooked, and that governments and employers have to make efforts to strive for decent work and put the foundations down during this emergency. Next, please. Yeah. So anyway, decent work. I'm just going to go very quickly through this. So you have these slides. Decent work is work that is productive and delivers a fair income, security in the workforce, social protection for families and healthcare workers, better prospects for personal development and social integration, freedom to express concerns, and equal opportunity and treatment for all men and women. So, though the right to decent work may be abridged during times of emergency, this goal can be pursued as health systems are rebuilt during recovery after this first wave of COVID. Next. Next, please. So my final prefatory remark here is when we address gender issues in the health workforce, we are obliged to understand and address the operation of the gender binary, the tyranny of the gender binary, the rigidities, the workforce rigidities, the labor force rigidities created by the gender binary. I'm just putting this in front of you to say that a report came out last year for the Nursing Now campaign on investing in the power of nurse leadership. What will it take? And for those of you who are interested in the workings of gender norms in the workforce, if you want a deep understanding of that, please take a look at this, because you will, I think it'll give you a good background on some of the points that you should be thinking about anyway. Anyway, next, all of that to say that, you know, here are some of the issues that we have researched in the last 15 years about how gender operates in the health workforce. Girls drop out of school for marriage, domestic and reproductive labor, or in response to sexual harassment at schools. And this obviously has, you know, ultimately, whether you are in a sustainable development mode or a crisis mode, this has an impact on the health worker pipeline. Women's lack of reproductive autonomy makes it hard to plan for a professional career in health. Exclusion from sites of power and decision-making make it hard also to plan a career. Work and family conflict and restricted mobility make it difficult for women to be recruited or choose careers or be deployed where a job is, particularly in early reproductive years. There is a constellation of gender biases, stereotypes, and discriminations around pregnancy and family responsibilities or sexual harassment that limit women's full participation in the health workforce. Occupational segregation and the gender pay gap exists in many countries that we have documented. And this is where men are typically concentrated in the higher organizational hierarchies with better compensation. And this continues to be a gender issue in the workforce. the the unequal and unpaid burden of domestic labor, reproductive and family care. These exist whether women are in school or not, whether they are in work or not. The devaluation of women-identified jobs, which, like nursing, like midwifery, like community health work, the frontline health jobs, the devaluation of these jobs, they are concentrated at the front lines. And I wonder whether the habitual neglect of all aspects of occupational safety and health at the front lines, and that includes workplace violence and harassment, is possibly related to the devaluation of frontline jobs. Typically, health systems policymakers and planners lack awareness of these issues, how gender operates in the workforce. They tend to have a weak gender lens, shall we say. So let's go on now to the next slide. Next slide, please. Yeah. So gender norms and inequalities during the COVID-19 emergency. I have to tell you that I'm going to say straight out, I don't think we know what's happening. I don't think we have data. We have some indications, and we can speculate on some things based on what we knew about the healthcare workforce and how gender operates. The school closures, the disruption of education, increased caregiving burden on girls, increased social exclusion. These are going to have dire implications for their educational, economic, and health outcomes, as well as for the health workforce pipeline. The increases in intimate partner and sexual violence that many of you have already mentioned. We don't know what's happening now, but likely it is possible that these will be exacerbated in work-related violence and harassment. Reports are coming out. Oh dear heavens! Well, it looks to me like I have 1 minute to wrap up. So let me just say, take a look at these. I want to just point out here that let's see. I want to point out something here. This is called Heroes at a Distance and Lepers Up Close, related to possible stigma of health workers who are exposed to infection. We don't know the gender difference of this, gender differences between men, women, or the intersectional differences here. But it's a very disturbing phenomenon, and that will have an impact on how effective health workers can be. You know, there are a lot of things that I have not gotten to, so let me stop now, and we can pick up some of these later. And you have my slides, and we can discuss this at another point.
Thank you, Candy, and sorry to rush you. We want to make sure that all of our presenters get a chance to speak. So I'm going to turn the floor to Giovanna. Please proceed, Giovanna.
Thank you.
Over to you.
Thank you very much. Hi, everybody. It's a pleasure to be part of this conversation, and thank you very much to the core group for inviting me. So over the next 10 minutes, I'm going to talk specifically about the impact of COVID-19 on men. And when I say men, I'm actually referring to masculinity. So I'm not going to talk about the impact from a biological perspective, but much more I'm going to focus on the social construction of masculinity, what it means to be a man at a time of COVID, what are the consequences, and how we all play a role in enforcing harmful stereotypes about manhood, whether we're men, women, or individuals of all gender identities. And this is at the core of what we do as an organization at Promundo. I'm also going to refer to some studies that we've done before COVID and just at the beginning of the pandemic, and they are all on our website for you to find in case you're interested. In terms of the solutions that I'm going to highlight at the end of the presentation, these are all going to be gender transformative, to use a term that Liz at the beginning today mentioned. That is really, I'm going to focus on COVID and men, both of course as a crisis, teasing out the impact that it's having on gender power relations, but also as an opportunity to change in a positive way existing gender power dynamics. So when we talk about men and COVID, of course, we need to use a gender analysis, a gender responsive lens to discuss the pandemic. And I thought I would start here by sharing a couple of assumptions that will guide my presentation, just to make sure that we are all on the same page. First of all is that even though this presentation is going to focus specifically on men and COVID-19, a lot of what I'm going to talk about is not unique to COVID-19. As we know, crises like the pandemic, like the previous HIV/AIDS pandemic, like other epidemics or natural disasters or conflict-related crises, they all accentuate existing dynamics related to gender norms. And this is the same that's happening now. So again, even though we're talking about COVID-specific elements, the underlying causes of a lot of the dynamics we're seeing now could have been prevented by action taken earlier before the pandemic. The other two elements that are going to kind of be a leitmotif during the presentation is that I'm going to try to encourage us to use an intersectional lens. We're talking about men, but let's try to remember which men specifically we're talking about, and also relational lens. That is, as we talk about the impact of men, of course, we should not talk about this in isolation. We've heard from the previous presenters about the massive impact that COVID-19 is having on women and children. And so all of this needs to be considered together. So first of all, the first fact that I wanted to highlight today is that we have seen, looking at the news, at articles on a lot of the media, that there seems to be some evidence that men may be dying from COVID-19 more than women. Some countries have published data. For instance, Italy, the country I'm from, shows that about 70% of the victims are indeed men. Some other countries have not published any data, like the UK, in terms of gender disaggregated data. So it's still early to confirm this, but there seems to be a trend. And here you can see on this slide also some data from the US. But so why is it? If that's the case, why is it that men are dying in greater numbers? Well, here, just as I was saying before, the root causes are probably some specific to COVID, but also reflect a general trend that we see globally. Of course, it's a mix of biological and social determinant factors. From a biological perspective, that is not my field, but the reality is that we don't know much yet, also because a lot of the medical research focuses on male bodies. And so we don't know really what makes female bodies more resistant to COVID. But we do know that also there are social determinant aspects that are playing a role in the greater mortality of men from COVID-19. And this is the case, we've seen it also in other pandemics like HIV/AIDS. And in general, if we look at the global burden of disease, we see that indeed men have greater mortality than women across a lot of the leading causes of death. And in general, they die about 5 years earlier than women. For those of you interested in learning more about this, I recommend the resource on this slide, Masculine Norms and Men's Health, that we published before COVID, and really tries to look at these general trends that, of course, are exacerbating during a pandemic, but were there even before the pandemic. And it really focuses on the masculine norms, so on the social determinant aspect, which can be summarized in a very concise way, given the nature of the presentation, in terms of like the societal pressure that are put on men to conform to certain harmful standards of being a real man, whether it's pressure imposed by other men, whether it's pressure imposed by their own families or the media or the broader community. How these norms impact men's risk-taking behaviors and in turn impact health outcomes is crucial to understand why we are seeing greater mortality amongst men. Let's think, for instance, about the stereotype notion of men not needing to seek help, and how this translates, in many cases, into men getting to get treatment only when it's too late, men avoiding preventive measures, such as in the case of COVID cleaning their hands, or in men adopting negative coping mechanisms, for instance, for their mental health in a time where quarantine is imposing a lot of stress such as, for instance, alcohol abuse, substance abuse, smoking. So this is what we're going to focus about in this presentation. And this pressure starts very, very early. In this slide, I am sharing with you results from a nationally representative survey that we conducted in the US right at the beginning of the pandemic with parents of children ages 4 to 14. And we asked basically a number of questions centered around how much they thought their kids felt comfortable disclosing their own weakness or loneliness and sadness in the current society. And as you can see, the responses are pretty discouraging. So it really shows how early notions of harmful masculinity start to be ingrained in the ways in which we raise our children, with long-term consequences about their health as well. And this is bad, of course, for men themselves, but it's bad for society as a whole. Here I am sharing an analysis that we conducted pre-COVID about the cost of harmful masculine norms for society. We look at specific, at a small selected number of cost categories for a subset of the population. Specifically here I'm including data for the costs associated with health outcomes for men in the US, ages 18 to 30.
Giovanna, I'm going to give you a 1-minute warning.
Okay.
Thank you. Sorry to cut you off.
No problem. And we see that basically here the budget is equivalent to the CDC budget. So it's a really large budget, right? So the cost, it's important to keep in mind for future action, because again, it's not just a large cost during COVID, but it's a large cost to society as a whole. To conclude, I'm just skipping here because I discussed some of these issues over the course of representation already, and I just wanted to focus on what we can do about it then. Well, we've heard from many presenters that we need more data. We really don't know much yet about the impact of COVID. So gender disaggregated data, of course, but also data that is truly intersectional. It takes into account how structural factors are impacting on individuals, whether from an income perspective, from an immigration status perspective, etc. We also need evidence-based policies that are responsive and are based on a gender analysis. We need universal access to healthcare. We are seeing that that works better. We need to focus on men specifically. We need policies that encourage men to take a more proactive role in caregiving, both taking care of themselves to prevent mortality, taking care of their families and children to reduce women's unfair burden when it comes to caregiving, but also to be more engaged in paid work around caregiving. As Candy was mentioning, there is still very much a female-populated profession. And to conclude, just one aspirational element for those of us who are socially distancing at home. This is a crisis, but it's also an excellent opportunity for us at home with our sons to have conversations about what it means to be a good man, and more importantly, a good person, and to promote healthy masculinities starting from our own household. Thank you very much for your attention.
Thank you, Giovanna. Appreciate it. We'll have our last presenter, Anne, from Women in Global Health. Please proceed. Thanks.
Thank you. Thank you, everybody. And the great thing about coming last is that everybody has said everything I was going to say, so that's absolutely perfect. We start off by saying that global health security depends on women, and I think everything that we've heard so far has reinforced that. I want to let you know that if you haven't seen it already, in February, Women in Global Health put together Operation 50/50, which is a crowdsourced list of women who are global health experts, more than 100 of them. And the reason we did that was to answer the question, where are the women? Because we weren't seeing women being appointed in equal numbers on decision-making groups at global and national level on COVID-19. And we weren't seeing women equally represented in media commentary, even though we know that women are 70% of the global health workforce. So Women in Global Health have come out with 5 asks for global health security. And I think all of them, again, have been reinforced by the earlier speakers. And number one is very much equal representation, that we want equal representation from for women on decision-making bodies, on global health security and expert groups. When we've asked for that, we're told right now, as we often are in post-conflict situations, that this is not the time. This is not the time for special pleading. And we argue that it is absolutely the time to bring maximum talent to the table, expertise, and diverse perspectives. And thank you to the speaker who mentioned people with disabilities. We need all perspectives at the table. Our second point, and I think Candy Newman has emphasized this so well, is that applause at the moment is fine. Health workers, they're doing a great job, but what they need is decent and safe work. That's better than applause. And we need to put this whole thing back better in a stronger, on a stronger, more secure foundation. We have a global shortage of 40 million health workers, 18 million health workers in low-income countries right now to achieve universal health coverage. So COVID-19 is hitting health systems that are already desperately short of health workers. Women are 70% of the health workforce, as we've heard, but they need decent working conditions to enable them to care for patients, for families, and themselves. And that's what we're asking for: decent and safe working conditions for all health workers, but the majority being women. We're asking fair pay and shared unpaid work, and we've heard that. We will recognise the value of women's unpaid work by including it in the formal labour market, redistributing unpaid family care equally between men and women. What we know at the moment is that the poorest women, some of the poorest women in the world, are subsidising global health with their unpaid labour. About half the work that women contribute to global health is unpaid, and that's in two forms. Women are doing unpaid jobs within health systems, they're vaccinators, they're community health workers, etc. But it's also the work that women are doing unpaid within their families and communities. That provides a very fragile foundation for everybody's global health. Fourthly, we're asking, and I think with health security and to global health in general, because of the data which is sex disaggregated, intersectional, and also gender responsive, we're pretty much working blind. We really don't know how gender is playing out, and at the end of this, we need to have the data to show how it did actually play out and how we can do this better in future. And we're including here, including women equally in clinical trials, for example, and research, looking at some of the biological and behavioral risk factors. We are looking at specific research to address the role of women on global health security, that role that women can play in family and community health promotion. But we're also looking at, we want research to look at the impact of female decision makers, including parliamentarians. Are female parliamentarians doing this differently? Are they doing it better? And we want, as others have called for, specific research. Let's look at the impact on women's sexual and reproductive health, gender-based violence, girls' education, etc. We need those gender-responsive approaches. Finally, we're asking for well-funded organizations, and particularly we're arguing for women's movements and women's organizations at global and national level, but particularly at national level in low and middle income countries, to be properly funded. And what we know when we track the funding is that only 1% of gender-focused donor aid to civil society in 2017 to 2018 went to women's NGOs in low-income countries. That's just 1%. We are not properly funding the organizations that are on the front line, particularly women's organizations in low and middle income countries. We need to unleash their capacity with proper funding. So what we're saying is that this can't be business as usual. When we put this back together again, things have to change. And one of the reasons that we will struggle with the response to the coronavirus is that we have not built global health on an equal and solid basis. We need to follow the money. Where will the money go in this crisis? Will it go to those women's frontline organizations? Will it go to revaluing the work that women do, not only in health, but in the home? So we have an opportunity now to really build back global health in a much stronger way, and we have to take that opportunity. Thank you.
Thank you, Anne. That ends our presentation, but I want to bring back a question that was brought up by Tori Pell, and your last point of the 5 asks sort of is linked with this question. So Tori asked of local women's organizations are already responding to many of the issues raised in the webinar. However, many of these organizations are also concerned about funding and being able to continue their work. Many organizations receive funding on a project or programming basis, which does not allow them the flexibility to adapt to the needs of their communities when an emergency arises. How can we help move the local women's organization to respond to crisis situations and funding models that allow for flexibility and adaptation for local organizations? If one of the speakers wants to take on that question, one or two. We just have a few minutes left, and then there's another question that the audience wants to ask of Giovanni and Promundo.
Lisa, it's Anne here. If I can say, I think one of the most important things is just to keep talking about where the money is going and tracking where the money is going. And I think this is an appeal to WHO member states, philanthropic organizations, World Bank, and others to really be considering how they're going to set up flexible funding to get it to those women's organizations on the front line.
Okay, thank you, Anne. Anyone else? So,
this is Samira. May I come in for a couple half minutes?
Please do, Samir.
Sure, thanks. I mean, one of the things we've been trying to do at a country and even subnational basis is that crowdsourcing of funds and reprioritizing everything else. So one of the things that we've also been doing is looking at our partners for delivery, for implementation, and that would involve civil society organizations and other local community organizations, among which I am sure there are going to be a lot of women organizations and advocacy ones. Over. Thank you.
Right, thank you. And now a question for Giovanna. What other factors than risky behaviors and poor hygiene has Promundo identified? Can you speak to that? And this has to do with, other professional vulnerabilities and to disease and fatalities, such as bus and tram drivers, mailmen, food delivery, construction and police, etc.
Absolutely. Yeah, sure. I mean, the risky behaviors are across the spectrum, right? Are both related to the professional life. So again, the tendency of men to take on more risk because it's more manly to do so means taking more occupational hazard risks or being engaged in traffic accidents, for instance. And then in terms of personal behaviors related to COVID, very relevant, of course, is smoking. That's been mentioned already during this presentation. We saw it specifically in China being probably a leading factor of the difference in terms of mortality between men and women, less so in Italy and in the US, and also poor nutrition. Again, the fact that men don't take care of their bodies, it's another leading element. But of course, this also affects the health of the people in their families, because just as they don't take care of themselves, they don't they risk not taking care of others. The other thing I just wanted to mention briefly with regard to the previous question, in terms of women's rights organization at the grassroots level, something that we as Promundo are doing, and I'm sure many others are doing as well, to address the immediate need is having one-on-one conversations with funders to encourage the transformation of project funding into core funding to support our grassroots partners. So I think that's something that some funders have been particularly responsive to in this moment of crisis.
Thank you, Anne. We have a lot more questions, but unfortunately we're running out of time. We're a minute over. So I am going to pass the floor to Lisa, who will do the closing for this presentation.
Yeah, Caroline, I think we can take a couple more questions because if you don't mind, just maybe two more, and then I'll close. Thanks.
Okay. I see a question in the chat that says, is anything being done to support access to GPV services during this time? Any one of the speakers can take on that question.
These go ahead, please.
I was just going to say that there are different examples of different countries, but there's an interesting example in France, which is quite deliberately set up measures and accommodation, temporary accommodation for women to be able to escape gender-based violence at home.
Okay, thanks.
I can just speak to the MENA region. I know the European Union and other donors within the MENA region have taken quite an interest in GBV response provision and how we can adapt that for our context. So I know there is some interest from donors to increase our resource provision around GBV and a lot of flexibility around reallocating resources. So there is some interest in this region as well.
Okay, and there are still, I'll do one more question, and I think it was left over from the last round, but in developing countries, digital logistics and financial literacy is very low. In the case of lockdown, there will be food security challenges. What can be done?
Hi, this is Samira. I am going to try and address this. Within the food security, the World Bank at least is working with the international organizations and other international NGOs for food delivery, WFP, FAO, and others. One of the things we are also promoting within the agriculture and food security is working with local cooperatives to actually redistribute whatever they have in their storages, and also trying to promote something that is more easier to scale up and distribute as well to needy families. This is part of our social assistance and social protection program besides the cash transfer. And I think the discussion around the access to digital platforms for education is very extensive. So I'll just stop here on the food security. Thank you.
Okay, and there is just a question asking for any supporting technical notes that you may have on food security. If you could provide those, that would be excellent.
Sure. We have a compendium of documents that's also on our external website, and I'll be able to share this link with the core group colleagues, and then it can be disseminated, of course.
Thank you, Samira. Julie and Lisa, I will turn it over to you for closing remarks and wrapping up the presentation.
Yeah, thank you very, very much. Avani, can you just put the slide with the resources? Thank you. Thank you very much, Julie, for putting this together. This is just a sample of some of the gender resources that we've been uploading to our website, and you are also able to go to the website and upload. So we've had, I think, over 2,000 hits in the past 2 weeks. So please go ahead. I know a lot of people are already doing this, but we encourage you to also share. But please take a look at those. I want to thank all of our presenters, as well as Julie and Ivani, who have been helping with the coordination, Carolina for the great moderation and pulling this together, Anushka, Courtney, Anne, Candy, and Giovanni. During the digital health technology calls we had, we specifically asked about how they are incorporating gender issues and addressing in their development gender, and all of the people were silent. And so we recognize that across every aspect of this response, we need a gender transformative approach. And so I'm very, very excited that today we got to dive into this just a little bit. And we hope to continue this conversation and all of the great work that you are all doing. I do want to thank all of the health workers. It is, as many mentioned, it's health workers. I myself am a nurse. I know many on this call are frontline health workers, nurses, doctors, CHWs. So I want to shout out, and we support you. We will continue to raise our voices for you. We will promote the 5 asks. And we hope that you remain safe in treating and preventing COVID infections in your communities and in health services. We will have a summary of this call available and send it out. And if any of you, what we've been doing is identifying gaps in resources and in topics, and forming smaller working groups to actually get our hands dirty, working on some of these issues. One example is home-based care of COVID patients. So now there's a smaller working group that multiple organizations were working on the same thing. We help pull them together to save resources and to get all these great minds together so we don't duplicate. So if you're interested in that, reach out to me. I'm putting, again, my email in the chat box, or anyone else at Core Group. Please reach out to them. Thank you for your time. Happy Easter, happy Passover, and have a great weekend. Thank you for all of your work, and thanks for joining us today.
Thank you, Lisa. Thanks, everyone, for participating.
Thank you.
Have a great weekend.
Thank you.
Bye.
Very much.